guess we can get started here then. So welcome everybody. This is going to be our second Q&A session. So I wanted to welcome you all back again if this is your second time. My name is Rina Hisamatsu. I am a registered dietitian for the Family Medicine Clinic at Domino's Farms, as well as the health educator for MCT2D. We're also joined today by the lovely Heidi Diaz, who is our program co-director and pharmacist lead for MCT2D.
Hi, everybody. So happy to be here with Rina. Thank you.
All righty. So today's conversation is going to be about how we can start, how to start the conversation on the low carbohydrate meal plans with our patients. So to take you through a little bit of an overview today, I wanted to discuss some of the key themes that we'll be discussing today. So around the, in terms of counseling, we wanted to sort of go over some of the key themes around motivational interviewing as sort of a strategy for counseling with our patients. We wanted to discuss different types of MI techniques and themes and skills that we can use to achieve success with our patients. We're going to be talking about, some recommendations on maybe perhaps how we can start a conversation and how we can sort of tweak our conversation to identify suitable patients that may be interested in pursuing the low carbohydrate meal plan. We'll also talk about recognizing the challenges, how we can perhaps make adjustments to medications, which will be led by Heidi, and then also maybe working together to set some initial goals. All righty, so let's dive into it. So first, before we wanted to sort of start our session today by asking a couple of questions. We have a poll here. We wanted to get a better sense of sort of our audience today to better understand, your experiences with counseling on a low carbohydrate meal plan. Do you have experience? And if so, we would love to know, sort of how often or how frequently you counsel patients at your sites on the low carbohydrate meal plan. So let me take a look here and we'll get the poll started. Okay, so we have a couple of poll questions here. And can everybody see that the question has been launched? Oh, yep, we're getting some answers here. Perfect. We have everyone has answered with a yes. In terms of the question is, have you ever had a discussion with a type 2 diabetes patient around a low carbohydrate diet? Great. All right, so that's really great to know that, that everybody here has some experience. And let me take a look at the next question. All right, so we have one more question that we wanted to launch here. So the question is, for those who said yes, how many type 2 diabetes patients have you ever counseled on a low carbohydrate meal plan? All right, so we have some varying answers here. 11% said 1 to 5, 17% we have 5 to 10 patients, and 74% answered 10 plus. So that's a really well-rounded variety of answers that we have here. All righty. All righty, good deal. So thank you all so much for participating in the poll questions. All right, so let's dive into the first topic of motivational interviewing. Okay, so we wanted to first and foremost talk a little bit about this concept as a counseling technique that may be effective to use with our patient population. So motivational interviewing, as some of you may be familiar with, is a widely used counseling technique that is very effective for in behavior change. So it was, first discovered around, and it's been around for a few decades now. First started in the 80s, and it dives into sort of the essence of building rapport and trust with a patient, and therefore creating the blueprint for collaborative work between the healthcare team and the patient. Importantly, it provides the patients with the tools to take on self-management skills by tapping into their intrinsic or personal motivations. It's very much a collaborative and goal-oriented style of communication that's can be seen as a significant shift from the traditional way that we may have been approaching healthcare. So there was a systematic review in 2016 that looked at several different randomized control trials, and it assessed the effects of motivational interviewing on behavior change outcomes, as well as clinical outcomes in patients with type 2 diabetes. Of the studies that they had identified, they found that motivational interviewing had significant impact on the dietary behaviors and weight loss in this population. We do want to acknowledge that motivational interviewing is a skill that takes time, of course, to develop and to refine, and therefore we wanted to sort of make it as part of our conversation today, because we do realize that it takes practice and time to build confidence in motivational interviewing. So we wanted to go through some of the core processes around MI, which is motivational interviewing. So the 4 stages of MI are sort of broken down into, as you can see on the slide here, there's engage, focus, evoke, and plan. So these are some of the main themes that we can use when having a counseling session with our patients. So first and foremost is to engage. So this involves building that initial relationship with our patients, building trust, partnership, and of course, using empathy to build understanding with our patients. You may agree that building that initial trust is really useful because it can help to break the ice, right? It can help to loosen up any tension, and open up really the door for open communication. The second process, or the second theme, is to focus. So based on what our patients are sharing with us, we may want to reflect and sort of draw focus into 1 or 2 main themes for that session. Focusing can help us to sort of keep our session from drifting unproductively. Number 3 is going to be to evoke. So this sort of dives into, trying to understand and evoke our patients' thoughts and feelings, their motivations, and their biggest concerns. Asking them, thinking about where are they in the state of change? Are they in the pre-contemplation, contemplation, or are they ready? Are they in the preparation stage at this moment in time? And last but not least is to plan. So together with our patients, creating a few patient-centered goals to also support self-efficacy, self-confidence during the session. All right, so these are, excuse me. All right, so these are some of the core skills. So these are some of the motivational interviewing tools that can support clinicians when counseling with their patients on these 4 phases. We know that change occurs when patients are given the platform to really voice their own reasons for their change. So really tapping into their inner and intrinsic motivations. So these skills can really help to encourage patients to explore that, to explore their problems, to explore their concerns, and to talk about it, to better understand that. So some of these, the skills are sort of, the acronym is OARS, as you may be familiar with. So the O stands for open-ended questions. This is going to be more exploratory than the simple yes or no answer, and it helps patients to express more information. So, for example, tell me about your reasons for wanting to improve your management of blood sugars. Number two is going to be affirmations. So these are positive statements of appreciations, of understanding, of compliments. It can show understanding and empathy towards our patients. So, throwing in, this can examples such as, thank you so much for sharing your journey with me. It sounds like you're very determined to get back on track. These are all positive, affirmative statements that can really help to build confidence and build trust with our patients. So number three is reflective listening. As the term signifies, this is about sort of listening and sort of repeating or rephrasing. It's a great way to make sure that we have accurately heard and understood the information that the patients have told us about, rather than to assume. Last but not least, we have summarize. So a summary, we use summaries to sort of reinforce what has been said and to show that you have been listening, and also to prepare the clients to, all right, let's start working on some patient-centered goals and to move forward from there. All right. So oftentimes, starting that initial conversation can be the most challenging part of a counseling session. So using some of the MI themes and the skills that we had discussed, I wanted to sort of go through some potential ideas on how we can maybe start that initial conversation. So these questions may be elicited at the initial encounter with a patient to help identify where, it can help to identify individuals where the low carbohydrate meal plan can be the most effective in their treatment plan. So first and foremost, does your patient have the desire to better manage their diabetes? Are they concerned about where they're at right now? Do they want to take charge of their health? So sort of engaging and evoking the patient, their concerns, and to understand their main motivations can be a first good step during a counseling session. Next, we might discuss whether or not the patients have heard about or know about the low carbohydrate meal plan. Do they have any past experience? Personally, in my practice, I hear a lot of, some patients will share with me that they have some experience with similar programs. So you may be familiar with the Atkins program. So that's something that I hear a lot in my practice as well. So, sort of seeing and understanding whether or not they've heard of it. If not, this could be a good cue to sort of discuss some of the benefits, right? If the patients haven't heard about a low carbohydrate meal plan, perhaps we can dive into sort of talking about whether if they would be interested to learn more about it and learn about some of the benefits that we know are associated, or some of the outcomes that we know are associated with a low carbohydrate meal plan. So these benefits may include, reduced hunger and cravings, improved blood sugar management, reduction in blood pressure, weight loss, increased energy, and such. So taking a moment here to pause can provide some time for the individual to really process the information and ask pertinent questions as needed. All right, so the next big question and the next big consideration, I think this is, one of the most important things, is whether or not our patients are interested in the foods that would be involved in a low carbohydrate meal plan, right? There's really there's not a lot of, oftentimes it could be a big barrier if patients themselves are not interested in the foods that it will involve. So sort of laying this question out there, discussing some of the type of foods that are involved in a low carbohydrate meal plan, I think can be a really important way for both the clinicians and the patients to really be a part of the process and in the decision making. So over the next few slides, we'll go over some of the main themes, the main foods that are recommended and on a low carbohydrate meal plan. Another important question is, are patients the patients committed to sticking to the low carbohydrate meal plan for 2 or 3 weeks? Oftentimes, other than the immediate improvements in blood sugars, other changes like weight loss, reduced cravings, increased energy can be maybe more noticeable after a few weeks. So it's really important to have that commitment to at least try it out, for the first 2 to 3 weeks to see their progress after that. All right, so as you can see here on the slide, these are some of the examples that are encouraged on a low carbohydrate meal plan. So a well-formulated low carbohydrate meal plan will include good quality protein sources coming from fish, poultry, meat, etc. For individuals who are looking for more vegetarian options, there's also tofu, tempeh, nuts and seeds that also contain protein. We also encourage non-starchy vegetables, including leafy greens, cruciferous vegetables, and other varieties, often vegetables that are grown above ground. Additionally, we also pair that together with healthy fats coming from olives, avocados, nuts and seeds, etc. The foods that we typically encourage are to be avoided are the high carbohydrate foods. So these include, sugary foods, most starchy foods like potatoes, rice, pasta, bread, to some extent, and highly refined carbohydrates, including refined cereals or wheat flour or white flour products. In this slide as well, we sort of go through sort of a summary of what we just discussed. But as you can see on the left-hand side on the foods to consume, we have the protein sources, we have the non-starchy vegetables, nuts and seeds, cheeses, as well as different types of dietary fat. The foods to avoid on the right-hand side are going to be refined grains, sweetened beverages, and packaged and processed foods, such as chips, cakes, granolas, etc. In the middle, we have foods that are limited, that we encourage are limited in terms of volume. So these are, depending on the level of carbohydrate restriction, we may incorporate some carbohydrates, which we encourage to come from complex sources, such as beans and lentils, starchy vegetables like sweet potatoes or yams or beets, whole grains like farro, quinoa, barley, etc., and some fruit as well. So for individuals who are interested in a very low carbohydrate meal plan, generally these carbohydrates are also avoided. So a very low carbohydrate meal plan is one that is typically less than 50 grams of carbohydrates a day. All right. Now, it's very important, once again, to recognize that the low carbohydrate meal plan is not a one-size-fits-all approach. So before recommending a low carbohydrate meal plan to your patient, it's important to consider factors such as cultural background, personal food preferences, personal goals, their previous experience, as well as their medical history too. Another important thing is to sort of assess the patient's baseline carbohydrate intake. I think that can provide a lot of valuable information through food recall, 24-hour food recall. It can inform clinicians in terms of where could be a good first stage of carbohydrate restriction. For example, if a patient's carbohydrate intake is around 250 grams right now, it may be reasonable to set an initial goal to 150 for the first week. And then seeing as, kind of checking in after the first week to see how they're doing, and then perhaps gradually going down to 100 or 130 grams per day. As an important reminder, so implementing a low carbohydrate lifestyle, it's an iterative process. So it's going to take a lot of refining and trialing and adapting based on each individual case. I think we're all still learning in this process and making this sort of a more widely used practice in our sites. And so we want this to be sort of not a fixed and rigid system, but sort of we want to learn from one another, learn from each other, and make tweaks as we go and continue to refine.
There's a question about when you're talking about carbohydrates, if you're talking total carbs or net carbs. I don't know if you want to address it now or we'll talk about it later.
Oh yeah, sure. Let's see. Perhaps we can address it now, and perhaps we can address it a little bit more in the discussion session. But these numbers that I provided here, these are total carbohydrates, not net carbohydrates. So thank you for asking. And we can definitely dive into the question of net carbohydrates too during the Q&A. All right. All right, so lastly, in terms of starting this conversation is asking and making sure we better understand whether patients, do they have the support needed, right? Do they have the support around them? In terms of support, the support could come, is coming from the healthcare team, right? Do we have the capacity to have the follow-ups needed for patients to keep track of their own health as well as to stay in touch with their healthcare team? Do they have the social support, family, friends, social groups that they can lean on and have guidance guidance around? Do they have the time? Can they commit the time to that's really required in terms of planning and preparing ahead of time? This is a significant lifestyle change when it comes to eating patterns. So, and we recognize that, and we recognize that the time that this might take and to prepare our patients to achieve success. Tools and resources. So I truly believe that these tools and resources can be a big part of their success, especially in the early stages. As they're learning more about carbohydrates and the carbohydrate content of food. So particularly, I typically encourage the use of food tracking apps. Not only does it help to sort of calculate and figure out what our baseline carbohydrate intake is, but it also helps us to sort of track the carbohydrate content of different types of foods. And it helps us to keep a tally and a reference as we sort of build confidence and build knowledge around it. So especially in the early stages, it can be a really useful tool to help patients stay on track. Of course, having a meal plan, having recipes and food lists are all integral to the success of a low carbohydrate meal plan. And in terms of, we'll discuss some of the available resources that we often encourage and use in our practice towards the end of our conversation here. All right, so we also wanted to address and note and recognize, acknowledge the challenges that we all face in clinical care. So in terms of the low carbohydrate eating pattern, as we had mentioned before, it takes a lot of time, right? In terms of counseling with our patient, in terms of the amount of education needed. So we recognize that, with time being of the essence in clinics throughout the nation, right? We understand that there's a time constraint and there is limited resources in terms of physicians to cover these routine visits. So we definitely see this as a limitation, as a challenge. As well as the availability of resources. So for example, limitations in the number of nurses or dietitians, MAs, other care managers within different clinic settings can really be difficult to implement these in the workflow. So, and lastly, frequency of follow-up, depending on the demand of the clinics, depending on the the demand and the capacity of the clinic, patients may not necessarily have the ability to have frequent follow-ups as they would like. So we do recognize all of these challenges, and we hope that over time we'll be able to figure out a good system within clinics and to really help to support one another. All right, so to recap on some of these considerations, once again, so the best way to really to sort of move towards, counseling on low carb and identifying patients is to try giving it a go. Maybe trying to find, instead of going full force, full on with all of our patients, maybe identify 1 or 2 suitable patients that may come into your clinic. So again, some of the biggest considerations would be to, assess where are they in their state of change? Are they committed and interested in the low carbohydrate meal plan? Do they have the self-management skills and time to dedicate to this lifestyle? Do they have the support needed? And in terms of medication management and their medical history, what are some medication adjustments that need to be made? And so here I wanted to allow for Heidi to discuss some of the adjustments that can be made with medications in regards to our type 2 diabetes population. All right, so let me stop sharing my screen for just a moment and allow Heidi to share hers.
Just getting everything here switched over. 1 second. There we go. All right. Can you all see my slides?
Yes, we can.
All right, great. Thanks, Rena. So,
absolutely.
To get started, so I think when a patient embarks on adopting a low carb eating pattern, it's really important to keep the stoplight rule in mind. And so I'm going to let it sit here for a second, and certainly we're going to share these slides. But I think this is, if you're like me, I remember things by pictures, and so I can very easily remember this. But this is a nice guide for what medications we might need to reduce, and then what medications we need to stop as a patient at the onset of a patient starting a very low carb diet. So as we dive into the actual medications, thinking through those, the medications that were in the red, in the stop zone, sulfonylureas, metagglutinides, insulin, particularly mealtime insulin. And why? Because of the risk for hypoglycemia. And so we really should be, for most patients, trying to definitely stop the secretologues. And then with insulin, we're going to get into in a little bit about how we manage that as a patient progresses. The other things to keep in mind, the stop category with a very low carb eating pattern is stopping SGLT2 inhibitors, which I'm sure I know we've been very vocal in making sure everybody's on the same page with this. But again, due to the increased risk of euglycemic ketoacidosis, this is very important to make sure you tell patients, make sure you confirm their understanding. And I would even say in my practice, sometimes when I tell them to stop medications, I always make it a point to ask again, just to ensure they didn't see the bottle sitting there and decide to add it back to their pill box. So reinforcement is always a good thing with the risk here. Finally, when it comes to the medications outside of basal insulin that were in that yellow zone, keep in mind TZDs and alpha glucidase inhibitors, so stuff like a carbose. Thought process here is it's not risk of hypoglycemia. TZDs, added weight gain. We're trying to help our patients lose weight, so we're kind of counterproductive there. In regards to the alpha glucidase inhibitors, a carbose, it's delaying the absorption of carbs. So if we're lowering carbohydrate the efficacy there with the patients in this eating pattern is not going to be as much. So no need to continue those meds. So I think one of the things that I love most in the many things that Dr. Grazda has taught me in the last year is, start simple. Start with getting your toes wet. Start with that green part of the light. So start this in your patients that are just on metformin, they're on GLPs, they're on DPP4s, because that risk in terms of hypoglycemia is not there as much. We still need to keep it in mind. We'll talk about that in a second. But I think that's where, Rena's already addressed some of the, challenges when it comes to time. I think when you're having these patients on these medications, that intense frequency of follow-up can be a little less, and you can also empower your patients a bit more and give them kind of advice what to do on their own. But I do not want to allow it to be thought that this doesn't mean we do not need to talk to patients about the risk of hypoglycemia. Even though these medications inherently are relatively low risk, it still needs to be talked about. And so we need patients to make sure they can monitor for hypoglycemia. We need patients to make sure they can monitor for hypotension. So make sure they understand the symptoms, make sure they have a home blood pressure cuff, because that can happen, the hypotension factor, just inherently with lowering their carbohydrates. And again, another reminder about SGLT2s. So just avoiding them in patients that are adopting anything less than 50 grams of carbs, and some might say even less than 70. I tend to personally practice conservatively, so 70 to 80 grams, I'm making sure they're not on an SGLT2. You can confidently have a patient on SGLT2 if they're eating more than 100 grams. But again, educating patients, making sure they understand, should they, in seeing results, patients get excited. They're losing weight, they're feeling good, they have more energy. And so they might quickly reduce things. And if you don't have them empowered to know that they need to stop this medication, they could get in trouble. So coming back to blood pressure, as I already mentioned, this is for all patients, regardless on what diabetes medications they are. This guideline that's at the bottom, and it's mentioned several times, both resources are here, and I would encourage you, when you're ready to embark in this, or if you haven't already, read these resources. They're very quick reads, but I think they offer a lot of guidance. So in regards to patients that have controlled blood pressure or edema is controlled, they recommend to either stop or decrease diuretics at the onset of adopting a very low carb diet. And it's something, again, that if you decide to go on the stop, you want to make sure your patient's monitoring their blood pressure. And if any of these symptoms, blood pressure starts to elevate, edema starts to return, you can always go back to the original dose, and maybe you don't reduce the medication as fast. The other thing, like we've talked about, is getting back to treating hypotension. And so this comes with awareness, making sure patients understand the symptoms of hypotension, especially having them get back to you with any sorts of reports of dizziness, fatigue. These can be certainly symptoms of hypotension that require medication adjustment. One of the things that I love that Dr. Grazda said is, empowering our patients. So telling them about these symptoms, if they encounter them, empowering them to skip their dose and contact the office. And so they're not going for days on end being hypotensive and not contacting and alerting anybody about this. I think I'd come back to this at the end, but I think it's a good time too to say, we need to engage the entire staff in this. So making sure, the nurses that are answering phones and talking to patients are kind of familiar with what to do in these cases. And then finally, just monitoring for hyponatremia. So as we start to reduce that carbohydrate, the body is losing water. And so that's where the component comes in with monitoring blood pressure, but then also dehydration. And then hyponatremia can play a part. So you also want to then consider other diuretics or medications that patient might be on that can impact that sodium level. There is a bullet here talking about a quick remedy, a home remedy to hyponatremia, but of course, making a little caveat that we need to keep in other comorbidities such as congestive heart failure in mind, that there could be other things in play when we're dealing with increasing hydration to avoid dehydration and altering sodium levels. And then as the graphic there in the lower right is a reminder, just hydration, hydration, hydration when feasible, when not complicating other disease states. So then if we think once you've gotten comfortable and maybe you've tried it out in some patients that are on the metformin, DPP-4, kind of starting to expand. And this guideline here, I think, is really helpful and has lots of great tables that are, just guidelines. The URL is here. You can just pick it up, pick that resource up at that URL. And so then we start to kind of move into more intense management that will require more follow-up. So talking about patients on insulin and secretagogues. So again, any patient taking insulin from the get-go, if they're going to adopt a lower carbohydrate diet, it needs to be very much understood to stay in close contact with the office, whether it's via the portal, whether maybe you have the ability for a nurse or a medical assistant to just simply check in. However you work this out, really weekly communication is pretty essential with patients on insulin. And so we'll get to that in a few more slides. One of the things also to keep in mind is if you do, in my opinion, try this in probably the most complex case, such as a patient on basal and bolus insulin, good idea to check a C-peptide. And that's just to make sure that your patient has endogenous insulin production and that we're not going to get ourselves into trouble by drastically reducing their insulin. We've also, no surprise here in terms of monitoring for hypoglycemia, but I think as a clinician who's always working on getting my patients to goal and getting their blood sugars that you've probably worked so hard to do down at goal, when you're having a patient who's adopting this type of eating pattern and we're trying to prevent any risk hypoglycemia to the patient, it is okay to let their blood sugars run a little higher than we're normally used to. So 150 up to 250 for about a month as you're starting to titrate, it's okay. And so that's something you got to tell yourself. Also something to tell your patients, because if they're anything like mine, once they get down to that goal, they start to panic a bit when they see their blood sugars going above 130, and that can make them a little concerned. When it comes to reducing insulin, again, I think one of the things to keep in mind is insulin adjustment is an art. It's not a science, so there's not anything prescriptive that I can, offer here, but general guidelines. I think some concepts to keep in mind is a lot's dependent on what patient you're starting with. Are they already at goal? And now they're adopting this eating pattern and maybe they're only on basal insulin. If they're not at goal, if their A1C is really high, above 10, 11, 12, this concept of reducing total daily dose by 50% might be too much. And so maybe you consider 30%. Again, consider what you feel is comfortable and what you have the ability to do for follow-up. The concept here, if you have a patient on basal bolus, is to try to make reductions in both. And then hopefully you're working towards, as you're reducing both, getting patient off bolus insulin, and then you're only dealing with one. And it might even mean at some point when you're getting closer to being off bolus, maybe you up basal a little to get them off the bolus sooner and then keep working on it. The idea would be to get basal insulin to about a half or 2/3 of total daily dose in that kind of scenario. And as from the first slide we looked at, secretologues, so metaglutinides, sulfonylureas, really consider stopping those at the onset of adopting a very low carbohydrate diet. Some might, if you have somebody with a super elevated A1C, maybe you want to wait till their blood sugars are more under 300 to take that away. But again, I usually practice on the conservative side. And so then if you keep that point in mind about letting the blood sugars rise up a little bit, it will be okay. So then as you continue to work with patients, just keeping in mind that it isn't always solely about blood sugar levels. And so keeping in mind where their current glycemic level is, but then also considering their degree of weight loss. So are they actively losing weight? If they are, you're going to be more aggressive in your reduction. If their weight is stabilized, maybe we need to adjust things. The other thing that the recommendations outline is if you have a patient who his weight is stable and we can't get their blood sugars under 250 and they are not already on a GLP, this might be a nice time to add a GLP to kind of help continue patient's weight loss process. And I think before we get to our last slide is just keep it in mind, as Rena already said, this is new for all of us. So this isn't easy. And so gaining experience, learning from others, learning from each patient to the next patient. We are all here learning together, but this, I think it's very satisfying to help patients, peel away these meds as they really adopt this new eating pattern. So to close up, if possible, again, to echo what Rena said earlier, we understand clinics are busy, we understand staff levels are low, we understand clinic size is variable. So, those first 1 to 2 months are really critical, especially for your patients on insulin, but the frequent follow-up and why it's so needed in those first 1 to 2 months is to ensure that patients losing weight and that their glycemic level is responding and that you're tapering off meds when possible. So the ideal scenario would be weekly for all patients. Doesn't necessarily mean to come in. It could be a phone call, it could be a portal message, it could be a video visit, if that is possible. And certainly if that's not possible for all patients, surely putting some particular attention to those patients on insulin for weekly follow-up just to ensure that they're safe. Teamwork, this can't be done alone. And so we realize that not all clinics have all the resources that other clinics have. And so I think MCT2D is doing our best to try to address this and provide resources and information that you can give to your patients to empower your patients on this, give them more information. And then finally acknowledging that this is hard work. It's new, it's not easy, but it is truly satisfying to see patients, decreasing their medications, having more energy, and truly having a happier and healthier life. So that is all I have. Did I stop sharing? I think I did.
I think you're still sharing, Heidi.
Oh yes, there we go.
Here we go. Thank you so much.
And I see there's chats. I don't know if we should.
Yeah, there. Do you want to address them now, Heidi, or?
Well, you have a couple more slides. So do you want to get through a couple more slides and then those can be the first questions I go back to in the Q&A?
Okay, sounds good. So let me we have just a few more slides here to address. All right. Okay, so the last few slides, so in the we wanted to discuss a little bit. So kind of, reviewing everything that we had discussed today. We wanted to, once again, sort of go back to, all right, having all of this information, what are one or two goals that we can identify, work together with our patients once we have identified maybe a few patients at our sites who are interested and suitable to in pursuing the low carbohydrate meal plan. So in terms of initial goals, we just put some ideas in terms of, what type of goals you might want to initially work on with your patients. What I find most helpful in terms of transitioning to a low carbohydrate meal plan is sort of work in a piecewise manner. So rather than going all out, changing overnight, 180 degrees, maybe transition one meal per week, or as we mentioned before, sort of gradually go down on their carbohydrate intake. So typically I find it's helpful for patients to maybe switch, let's say breakfast, work on breakfast for either 1 week or even 3 days, and then transition lunch to a low carb meal and then work on that for a few days, and then transition dinner. So that way they can gradually transition to a low carb lifestyle. Other ideas could be, all right, if you've identified that they have a high intake of sugar sweetened beverages, that could be an area to first work on, along with perhaps incorporating some low carb snacks. And then of course, adjusting medications as needed, as necessary. We encourage following up with your patients, ideally, in the first 1 or 2 weeks, if able. And then the last part, reporting back at the next session. We would love to we wanted to make this an interactive session. So we know that it can be overwhelming to sort of recommend low carb to every one of your patients. So maybe identifying 1 or 2, and then let us know next time we have our session on how some of these strategies went for you, how the counseling session went, and we would love to hear your feedback at our next talk. Oops. All right, a few important reminders here. So once again, we always encourage the low carbohydrate meal plan. It's a significant change. It's a lot to ask for our patients, right? So in terms of we always encourage that gradual transition, and to allow patients to sort of have a few weeks to adapt to the low carbohydrate meal plan. And then that way they can also report back to you and sort of troubleshoot as needed. In terms of the meal planning itself, we always encourage, choose quality proteins and fats. And also a reminder that a low carbohydrate meal plan is not a high protein diet. So that's, we want to make sure that we remind everybody of that. And the next thing to remember is, in order to sort of recommend a low carbohydrate meal plan, we also have to sort of break our fear of fats, right? So, we understand that it can be not common practice to sort of to recommend and encourage dietary fats into one's meal plans. However, slowly working on maybe choosing some quality fats from whole food sources like nuts and seeds, olives, olive oil, avocados, and fats found in animal products can be a great place to get those dietary fats in. And then last but not least, in regards to exercise, and perhaps we can talk more in details at another session, but in terms of exercise, we encourage that to be sort of used as a wellness tool rather than, a weight loss tool in this regard. And that way we can allow patients to really hone in and focus on their meal planning rather than sort of having the added stress of maybe thinking that they need to incorporate strenuous physical activity in order to see the weight loss progress or see the progress in or the outcomes that they're looking for. All right, and then last but not least, these are the teaching tools and resources that we currently have available for you all. Let me actually show you. Oops. Stop sharing for just a moment here. I want to show you the resource page that we have. Okay. All right, so these are all the links to the resources that I just provided in that slide. So one of the, I highly encourage, if you haven't already, to check out MCT2D's resource library. We have a lot of wonderful tools for providers and patients under the resource tab, which should be right here, as you can see, and we have provider resources and patient resources available. We also have, so the ADA has a tool for clinicians on the low carbohydrate meal plan. Similarly, we have another free resource called the low carb for any budget. And so this is a really great resource. It has a ton of recipes and just a guide in terms of how to start on a low carbohydrate meal plan. Some additional books if you're interested. So this is a good one called Always Hungry by Dr. David Ludwig, as well as for clinicians, I would recommend this book if you are not familiar with this. It's called The Art and Science of Low Carbohydrate Living. This has been a really useful tool for my reference as well for my reference as well. Last but not least, so Diet Doctor, also a really great resource. The reason I wanted to bring this up, they have a lot of articles and features here, but more importantly, they have thousands of recipes that are really wonderful and delicious that can be explored. So it's a really great resource and tool for patients if they're looking for recipes that they might be interested in. So if you go to recipes, they have a lot of different low carb recipes as well as keto recipes too. So check that out when you have the time. All right. Let me just share this screen. Oops.
I know we're running low on time, so I just wanted to try to address some of the questions in the chat. So Stephanie made a comment about patients using GLP agonists alone or asking about achieving ketosis with intermittent fasting. So her question is, do I use tirzepatide the same way I use GLP? So great question, Stephanie. To be fully transparent, haven't jumped on the tirzepatide bandwagon yet. I think mostly because most of the patients I see are fairly high risk cardiovascular from a cardiovascular perspective. So I'm not feeling comfortable losing that from switching over from some GLPs that are proven with CV protection to tirzepatide. I think there are some schools of thought that you could try it, and if you have a patient that has high risk and they want to, try to get some of the benefits from the glycemic lowering power and weight loss power that we've seen in these trials, that you could then add on an SGLT2 and make sure you're getting that until we get the results of the studies in 2024. But yeah, that's pretty much all I have to say on that topic for now. And then I think Erica, great comment here, just loving patients' reactions. And yes, I echo that. I think patients are more motivated when they start doing well and see the results of their work. And then Stephanie had another great question asking about which meds do we recommend when we discontinue insulin with patients with GFRs less than 35. So I know Dr. Gruz is on the line. For me, keeping in the spirit of kind of getting my toes wet and kind of starting simple. I have not tried very low carb in any of my CKD patients in that level. I think in 45 higher when we have some oral options, but I might, if Dr. Grazda is on, ask if she has any experience in that patient setting.
Yeah, I guess I would just echo what you said, Heidi, where if somebody has stage 4 CKD or higher, I tend not to use very low carb just because there is that uncertainty. I think over time, we're going to see that it can benefit that patient population, but as of now, we're not going there. I think when somebody has CKD and they initiate very low carb, the goal would be to not have to replace the insulin, but to get them off of insulin or on a reduced dose of insulin altogether.
Thank you. And then Dr. Grazda, will I still have you? I know the next question by Sharon was, what type of lipid results are you seeing? I'm thinking in my patients, I definitely haven't seen any worsening lipids, if that's where the question's going. And Sharon, if you want to unmute to kind of, or Dr. Grazda, if you want to share what you've seen. I think in my patients, when they adopt these lifestyle patterns, as their weight comes down, I'm seeing improvement in everything. But I can't really speak to dramatic lipid results.
I'm seeing with fast weight loss, just in general, that my patients tend to have their lipids go up in the short term and then sometimes come down. But I've read some plant health studies that suggest that keto diets and very low carbohydrate diets with extra fat, like cheeses and other things like that, actually increase atherosclerotic plaque. And that makes me really cautious in suggesting that kind of a diet to larger population, especially where in diabetes, where we already usually have high triglycerides to start with. And then the other thing I'll tell you is that I've had patients that I've counseled on a lower carbohydrate diet, and then they get really carb craving and they go off the diet. And I've seen really bad results in lipids when that happens. And maybe it's just when I measured them, but it's been in that small handful that I've actually counseled. So I'm really, again, curious about what others are finding and worried about it in general. Thanks.
Yeah, I know we're kind of short on time, but I'm happy to jump in. So I think what we know from the literature and what I would say I see in clinical practice as well is that on a very low carb diet, and I think response is pertaining specifically to the very low carb range, triglycerides predictably decrease. We know that's the most atherogenic lipid. HDL predictably increases. There is variability in what happens to the LDL. In some cases, it doesn't decrease, some cases it's stable, sometimes it decreases, some cases it increases, and in rare cases, it can increase a lot. There's still uncertainty about what that means. We do not measure LDL particle size in routine clinical practice. We know that small, dense LDL is most atherogenic. That's what we see on higher carb, low fat diets. And what we know when we do sort of NMR lipid studies and look at particle size is that when there's an increase in the LDL cholesterol on a low carb diet, it tends to be the larger, fluffier, less atherogenic particles. So still an area of uncertainty. So what does that mean? I think, again, we look at our patients as a whole picture. If you have somebody who is losing weight off medications, A1C is improved, triglycerides are decreased, and their LDL goes up, we pay attention to it because, we don't still have clinical uncertainty what that means. But I think when their overall picture is important, it's hard to zone in on one single number and say, this is unsafe or we should pivot away from the dietary approach. There are things that we can do, for example, adding more monounsaturated fats, things like olive oil in place of saturated fats, repeating the limits or the lipids once the patient has reached weight stability is really important, because I think, as you said, in the setting of rapid weight loss, when fats and cholesterol are being mobilized, we do see variability. So getting the patient to a weight stable state and repeating the lipids in a fasting state, I think is really important. And then some people, I mean, of course you can use a statin, but many patients or most patients with diabetes are already on a statin. Zetia or ezetimibe is often used in this patient population because the issue is thought to relate to increased cholesterol absorption from the gut. And so if you can kind of block that, then you can reduce lipid levels. So I think that there's a lot to talk about here. And maybe we circle back to this in another session, but I think that there's ways to sort of allow the patient to remain on a well-formulated low-carb diet, even in the setting of a LDL elevation.
Thank you. I appreciate all your comments.
Thanks, Dr. Graza. And then Rena, I think the last few questions, I don't know if you want to, I know we're a minute over. There was a question from Sarah and Stephanie.
Yes, so it's, okay, we can definitely address these questions now. And then anyone who needs to drop off can do so, and then we'll have the answers distributed via email as well. So let's see, so Sarah's question, I have a question regarding the low carb on a budget information provided through MCT2D. I often refer the patient to the green, yellow, and red food lists. If a patient is not doing keto, then should they still do the full fat options like butter? So that's a really good question. So in terms of, I'm glad that you're using the low carb on a budget resource. For patients who are not doing keto but low carb, I would encourage fats to be incorporated in not in high quantities as they would be in the very low carbohydrate meal plan. So butter is definitely one option. I always, in counseling, I generally recommend, when it comes to fats, choose one or two for your meals. For example, that could be fats coming in from the cuts of meat. Like for example, the ribeye steak or the fish, the fats that are naturally contained in a cut of salmon, plus maybe some butter or some oil to saute some vegetables. So thinking of adding fats that way, I think can be a more useful sort of guideline when counseling with patients. For example, so hopefully that answers your question, Sarah. Please let me, I'm not sure if she's still on or not. The second question for Stephanie, how much protein do you recommend, and do you calculate based on total weight or lean weight, any change in protein recommendations for patients with CKD? Okay, so in regards to protein recommendation, generally for, and this is an area I think we should have another discussion about. Generally for protein recommendations, that is going to, we typically recommend anywhere between 1 to 1.5 grams of protein per kilogram of ideal body weight for patients with obesity or overweight. And that typically equates to, anywhere between 20 to 25% of their total caloric intake. Generally, for as a rough guideline, I always start with sort of seeing where they are in terms of their baseline protein intake. Generally 70 to 100 grams of protein a day is a good place to start. And then again, it's an iterative process. So, following up with patients, how do you feel, usually 70 to 100 grams of protein is anywhere between 25 to 30 grams of protein per meal, assuming 3 meals a day. So try to maybe aim for 20 to 25 grams of protein. See how they feel after the meals. Are they noticing that they're still hungry right after their meals, or they're noticing that they're they're noticing that they get hungry, 1 or 2 hours after the meal? That's where maybe you can sort of come back and discuss, all right, how about we up the protein by just a little bit, or maybe we need to increase our intake of non-starchy vegetables. Are we making sure to incorporate that for bulk? Maybe we need to up the fats a little bit. So again, it's that iterative process, of trial and error. So hopefully that's a good start. a good place to start for everybody. All right. Any other questions? Okay, I think that wraps up most of the questions that we have here. So we'll make sure we'll put everything in writing, and we did receive some questions prior to our meeting today. So we'll be sending that over via email as well to provide some answers to those questions. Thank you all so much for coming today. We appreciate your time, and we hope to see you at the next session in September.
Thanks, everybody.
Thank you.